Welcome to Evolving Options for the Treatment of HCC with Immunotherapy and Liver-Directed Therapy. My name is Amanda Smolak. I'm an interventional radiologist at the Medical College of Wisconsin, and I focus on interventional oncology.
I'm Ben George. I'm a GI medical oncologist with a focus on upper GI malignancies at the Medical College of Wisconsin. I also direct our clinical trials office. The learning objectives for our talk are the following. Differentiate the clinical profiles of current and emerging immunotherapy agents for the management of hepatocellular carcinoma. Analyze relevant clinical trial data that utilizes immunotherapeutic agents either in combination or individually in the treatment of hepatocellular carcinoma patients. We will also try to spend some time looking at the multidisciplinary collaborative approach to treating hepatocellular carcinoma. We'll start with a series of questions and then transition to a few didactic slides that deal with data and then go over some cases. We will briefly go through a guideline review of immunotherapy in the treatment of hepatocellular carcinoma. There are several ongoing phase 3 trials that are investigating immunotherapeutic agents in the treatment of hepatocellular carcinoma. These trials are highlighted in yellow. Additionally, there are several clinical trials investigating therapies in the second-line treatment of patients with hepatocellular carcinoma, and these are highlighted in light green. Additionally, there are several phase 3 trials that are ongoing investigating second-line treatment of hepatocellular carcinoma, represented with the light green box. The hepatocellular carcinoma tumor microenvironment, or TME, is somewhat complex. The TME can vary based on the etiology that leads to hepatocellular carcinoma. Broadly, the TME can be pro-tumorigenic or anti-tumorigenic based on the immune composition. Based on transcriptomic classification of the tumor microenvironment, we know at minimum that there is an inflamed class of hepatocellular carcinoma and a non-inflamed class of hepatocellular carcinoma. It is important to recognize that this transcriptomic classification is utilized in the research realm and has not been prospectively validated. Nevertheless, this classification system can possibly serve as a framework for prospective clinical trial design. Therapeutic synergism is a necessity in hepatocellular carcinoma. We know that there are various classes of agents that have been approved for treatment of hepatocellular carcinoma. Specifically, we have anti-angiogenic agents, we have broad tyrosine kinase inhibitors, and we have immunotherapeutic agents. The goal of the current therapeutic trials is to try and figure out how these agents can be combined for therapeutic synergism, thus converting cold tumors or non-immunogenic hepatocellular carcinomas to hot tumors or tumors that respond very nicely to immunotherapy. Over the next few slides, we're going to cover a few pivotal phase 3 trials that investigate the use of immunotherapeutic agents in the frontline setting for patients with unresectable hepatocellular carcinoma. We will start off with the IMbrave 150 trial. This is a trial that evaluated patients with locally advanced or metastatic hepatocellular carcinoma with no exposure to prior systemic therapy. Patients were randomized in a 2-to-1 fashion to either a combination of bevacizumab and atezolizumab or sorafenib. The primary endpoints were overall survival or an independently assessed progression-free survival. The stratification factors included the region from which patients were recruited, ECOG performance status, vascular invasion, and baseline alpha-fetoprotein levels. The primary endpoint of overall survival was statistically significantly better in patients who received a combination of bevacizumab and atezolizumab compared to sorafenib, with a strong hazard ratio of 0.66 and a highly statistically significant p-value. The progression-free survival was also superior in the bevacizumab atezolizumab arm with a median progression-free survival of 6.9 months compared to 4.3 months in the sorafenib arm. The hazard ratio was 0.65 with a highly statistically significant p-value. The Himalaya trial investigated the role of dual immunotherapeutic agents in patients with treatment-naive, metastatic, or unresectable hepatocellular carcinoma. Patients had good performance status at recruitment with an ECOG performance status of 0 or 1, and they had Child-Pugh A class liver function. Patients with portal vein thrombus in the main portal vein were excluded. These patients did not need an endoscopy prior to enrollment in the trial because an anti-angiogenic agent was not used as a therapeutic component. Patients were randomized to 4 arms originally. The first arm included tremelimumab 300 milligrams single dose, along with durvalumab 1500 milligrams that was administered subsequently every 4 weeks, a second arm that utilized durvalumab as monotherapy, a third arm that utilized sorafenib as monotherapy, and a fourth arm that utilized a lower dose of tremelimumab at 75 milligrams along with durvalumab. However, this arm was subsequently closed. The primary endpoint was overall survival for tremelimumab 300 milligram dosing in combination with durvalumab versus sorafenib. There were several other endpoints that were looked at, including non-inferiority of durvalumab in comparison to sorafenib for overall survival, and also superiority of durvalumab in comparison to sorafenib for overall survival. Stratification factors included vascular invasion, etiology of liver disease, and performance status. The primary endpoint of overall survival was met for the combination arm of tremelimumab and durvalumab, with a median overall survival of 16.4 months in the tremelimumab durvalumab arm compared to 13.8 months for the single agent sorafenib, with a very strong hazard ratio and a p-value of 0.0035. Here is the design of the phase 3 COSMIC 312 trial. Patients with metastatic or unresectable hepatocellular carcinoma were randomized to cabozantinib in combination with atezolizumab or single-agent cabozantinib or a third arm of single-agent sorafenib in a 2:1:1 ratio with composite primary endpoints of progression-free survival and overall survival. Patients had to have ECOG performance status of 0 or 1 at recruitment and Child-Pugh class A liver function. Here are the results from the phase 3 COSMIC 312 trial. The primary endpoint of progression-free survival was statistically significantly better in the combination arm of cabozantinib with atezolizumab compared to sorafenib, with a strong hazard ratio and a significant p-value. However, the overall survival for cabozantinib and atezolizumab was very similar to sorafenib, with 15.4 months for median overall survival in the cabozantinib atezolizumab arm and 15.5 months in the sorafenib arm. Here is a summary of the reported phase 3 first-line combination trials of hepatocellular carcinoma. We have the IMbrave 150 trial that compared bevacizumab and atezolizumab to sorafenib, the Himalaya trial that compared the STRIDE regimen or tremelimumab 300 in combination with durvalumab to sorafenib, and COSMIC 312 that combined a combination of cabozantinib atezolizumab in comparison with sorafenib. The median overall survival, the progression-free survival, the response rates, and the median duration of response are all listed in the table. Here is the data from the CheckMate 040 trial, a second-line phase 1/2 trial of a combination of nivolumab and ipilimumab in patients with hepatocellular carcinoma. Patients with advanced hepatocellular carcinoma that progressed on or were intolerant to sorafenib were randomized to 3 combinations of nivolumab and ipilimumab with varying dosing and schedules. The overall objective response rates were fairly similar across the 3 groups, but the median overall survival was substantially better in the IPI-3 and the NIVO-1 arm. Important to note that the use of steroids for immune-related adverse events was fairly high in the study, with 51% of patients on the study requiring systemic steroid treatments. At this point, I will transition to Dr. Smolak, my colleague, who will talk about interventional radiology techniques for the treatment of hepatocellular carcinoma.
Thank you. Interventional oncology treatments can broadly be divided into 2 groups, transarterial therapies and ablation. Transarterial therapies include chemoembolization or TACE and radioembolization or Y90. Thermal-based ablation modalities, including cold-based therapies like cryoablation and heat-based therapies like microwave and radiofrequency ablation, and mechanically mediated ablation therapies. There's a lot of interest recently in combining local regional therapies and immunotherapy. There are many components to consider when looking at combining these therapies, and these include things such as the modality for treatment, the way the treatment is delivered in terms of the details of the intervention and the dosing of the material delivered, the schedule of treatments and the sequence of those treatments, the specifics of what immune modulators might be administered, and then what measures such as biomarkers in the blood or in the tissue, and how therapeutics are administered, whether that's arterially or intravenously. Virtually every interventional oncology therapy has some evidence showing that there is an impact of the treatment on the immune system. And this is a summary table from a review article briefly summarizing some of the changes that have been shown with different treatments. And you see here that these have been published over a wide range of years and are largely retrospective, but do show some evidence that these treatments can impact the immune system and might be able to be harnessed in combination with immunotherapies. I'll briefly go through the different modalities and what is known at this point about possible immune effects. In terms of ablation, both cryoablation and heat-based ablation methods may impact the immune system. Cryoablation is conventionally considered more immunogenic because of its mechanism of freezing and thawing cells, which does not thermally denature proteins, thereby potentially releasing these as intact antigens to stimulate the immune system. However, heat-based ablation modalities may also trigger the immune system by inducing an inflamed state with hyperemia and leading to an influx of immune cells into that inflamed environment. Bland embolization may impact the immune system, and this is evidence from an animal study showing that when tumors were embolized with a bland embolic, there was an influx of immune cells into the treated tumor, but this was also seen in tumor not treated. And so there was some off-target effect of the embolization on untreated tumor, suggesting a systemic response. There's evidence to show that Y90 may have some immune effects as well. This is a clinical study of Y90 treatment of HCC, showing both a local and systemic immune activation following Y90. And this is another study reiterating that Y90 can induce an immune response, showing an activation of an immune response with an increase in tumor infiltrating lymphocytes, and that this response peaked 1 month after treatment and decreasing thereafter, suggesting that there may be an optimal time at which to combine immunotherapies with radioembolization. As far as clinical trials supporting evidence for combining interventional oncology therapies with immunotherapies, the results are still early. This is a recent publication combining Y90 with nivolumab for advanced HCC. This was a phase 2 single arm, single center study looking at Y90 followed by nivolumab for patients with advanced HCC. This was a small study of 40 patients, all patients with preserved liver function. They found an objective response rate of 30%, which was better than the historical control with monotherapy alone. And this rate was even better, over 40% in patients that didn't have extrahepatic disease. The vast majority of treatments demonstrated intrahepatic tumor regression. Overall, the treatment was safe with a relatively low rate of grade 3 and 4 adverse events. This is a study presented at a recent ASCO GI meeting looking at pembrolizumab in combination with Y90 for patients with poor prognosis HCC. This is a multi-center single-arm study. It included poor prognosis HCC, meaning multifocal, portal vein tumor thrombus, and diffuse disease. The patients needed to be amenable for 1 or 2 Y90 sessions, and they also received pembrolizumab. The 6-month progression-free survival rate was near 60%, with a median progression-free survival of 8.6 months and a median time to progression of 9.9 months. And again, these results exceed the historical control and also again demonstrated a favorable toxicity profile for combining treatments. While these are early studies, we expect a lot more to come out in the future. There are a number of trials ongoing, and this is a summary table from a recent review article summarizing just the trials combining radioembolization with immune checkpoint inhibition that are ongoing. And there are additional studies with other interventional oncology methods. And so there's a lot to look forward to in this space regarding combination therapies.
Thank you, Dr. Smolak. We'll go through a couple of cases that illustrate the variable biology of patients with hepatocellular carcinoma and why it is important to take a multidisciplinary approach to treating patients with this diagnosis. A 73-year-old female with alcoholic cirrhosis was on surveillance through a hepatology clinic for approximately 2 years. A CT scan in January 2021 revealed 2 lesions, one in segment 5 and another in segment 7 that appeared indeterminate for hepatocellular carcinoma. A tumor thrombus was noted in the portal vein. Alpha-fetoprotein level was about 30. Liver function was Child-Pugh class A, and the patient had an ECOG performance status of 1. We discussed this case at a multidisciplinary liver conference to get consensus on an optimal treatment approach. Specifically, transplant was ruled out as a treatment option on account of the portal vein thrombus. We discussed instituting systemic therapy early versus focusing on liver-directed therapy. In the setting of just 2 lesions, one of them being indeterminate, we decided to move forward with liver-directed therapy. This patient was treated with transarterial chemoembolization, the segment 5 lesion, in February 2021. A CT scan performed a month after the TACE treatment demonstrated interval improvement of the treated segment 5 lesion, while the segment 7 lesion appeared more prominent. The portal vein thrombus in the right portal vein appeared worse as well. This case was again discussed at a multidisciplinary liver conference for consensus recommendations. We specifically discussed 2 approaches: liver-directed therapy alone versus folding in systemic therapy, considering the unfavorable biology that was noted in a short time. There was complete consensus to move forward with systemic therapy, and therefore this patient was initiated on a combination of bevacizumab and atezolizumab in March of 2021. Patient remained on this regimen until about August 2021. However, in the interim, based on multidisciplinary review and consensus recommendations from our group, she required radiotherapy to the portal vein thrombus and also required a TACE on account of local disease progression in the liver. Eventually, despite our multidisciplinary approaches, unequivocal disease progression was noted on imaging in September 2021. At that time, we contemplated the following options: switching to a second-line systemic therapy with a tyrosine kinase inhibitor, either lenvatinib, sorafenib, or cabozantinib. We briefly discussed the role of ramucirumab, however, decided not to move in that direction on account of an alpha-fetoprotein that was less than 400. We contemplated dual immunotherapy, either durvalumab in combination with tremelimumab or ipilimumab in combination with nivolumab. We also spent some time talking about the goals of therapy and whether best supportive care is the best approach in this scenario. After much discussion, we decided to move forward with lenvatinib to utilize a broad tyrosine kinase inhibitor in the treatment of this patient with alcoholic cirrhosis as the etiology leading to hepatocellular carcinoma. Unfortunately, soon after initiation of lenvatinib, this patient was admitted to the hospital with hepatic decompensation, resulting in encephalopathy and acute kidney injury. Despite attempts at dose modifying or attenuating the lenvatinib, the patient could not tolerate further dosing with lenvatinib. We contemplated next steps in the treatment of this patient, whether to utilize a different tyrosine kinase inhibitor, as in sorafenib or cabozantinib, versus dual immunotherapy or single agent immunotherapy. Patient was not ready to transition to hospice and still maintained reasonable liver function and good performance status. Ultimately, due to worsening liver function and performance status, this patient transitioned to best supportive care in summer of 2022. This case highlights both the importance and the necessity of multidisciplinary collaboration in the treatment of a patient with hepatocellular carcinoma. Systemic therapy, ultimately due to worsening liver function and performance status, this patient was transitioned to best supportive care in summer of 2022. This case highlights the necessity of multidisciplinary collaboration in the treatment of patients with hepatocellular carcinoma. At this point, Dr. Smolak will discuss the next case.
This was a patient with a history of autoimmune hepatitis who presented with a ruptured HCC. In the setting of an emergency, the next step in management for this patient was to primarily treat the bleeding and at the same time that will likely treat the tumor. This patient underwent a bland embolization to treat the bleeding tumor. This is a representative angiographic image from the procedure with the arrow highlighting the area of abnormality. This stabilized the patient, stopped the bleeding, and we saw him in follow-up to assess residual tumor. At the time of his follow-up, about a month after the emergent procedure, this was his MRI. This image is showing a mostly dead tumor from the treatment, but with an area of residual tumor where the arrow is pointing at the area of enhancement. At this point, the plan was to do additional liver-directed therapy to treat this small residual tumor. Here you see another angiographic image, which is representative from the TACE procedure. The arrow is pointing to residual tumor blush when we administered chemoembolization to treat this tumor. At 9 months follow-up, the patient presented with multifocal tumor recurrence. You see these images here showing multiple areas of tumor in the liver. He also had an enlarging flank nodule that you can see on the image on the right. I had multiple discussions with the patient's medical oncologist throughout his care about the appropriate steps in management of this patient. With his history of autoimmune hepatitis, the goal was to maximize local therapies if possible, as systemic therapy options were limited. Obviously, with a patient with a history of a ruptured tumor, now with a flank nodule, this was suspicious for extrahepatic spread of disease. So first, we wanted to confirm what this flank nodule was. This was biopsied and was negative for tumor. And that biopsy was repeated as a confirmation and was also negative for tumor. So once we confirmed that the tumor remained limited to the liver, we proceeded with our goal of maximizing liver-directed therapy options because of the background setting of autoimmune hepatitis and limited systemic agents. These images show additional recurrence of tumor now on the left side of the liver, and he again underwent chemoembolization and subsequent radioembolization to treat recurrent tumor. Ultimately, the patient progressed to multifocal bilobar recurrence of tumor. At that point, given the burden of disease, he was transitioned to systemic therapy, with lenvatinib being the best option in this setting for him. This case highlights the collaborative nature between medical oncology and interventional radiology, as well as the other specialists caring for these patients. With this patient in particular being limited with systemic treatment options for his HCC, we were able to maximize liver-directed therapy while maintaining his liver function and performance status and controlling tumor for more than 18 months before he ultimately transitioned to systemic therapy and unfortunately ultimately was transitioned to hospice. I'll turn the slides back to Dr. George.
Thank you so much, Dr. Smolak. Here are the summary points from our discussion thus far. The past 5 years have seen substantial progress in treatment options and modalities for first and second line treatment of advanced hepatocellular carcinoma. The plethora of treatment options available certainly place additional emphasis on multidisciplinary collaboration between the various oncologic specialists involved in the treatment of hepatocellular carcinoma. As we all know, patients with hepatocellular carcinoma have various underlying comorbid conditions that complicate their care and the choice of right treatment strategies. In that setting, personalizing treatment strategies based on the burden of disease, the underlying etiology of liver disease that led to the hepatocellular carcinoma, and even focusing on factors like social determinants of health are crucial to optimizing treatments for these patients. There are several areas of unmet needs, specifically identifying patients with hepatocellular carcinoma who have limited burden of disease and have good liver function is pivotal to maximizing treatment approaches. Once we identify these patients early, it is important for the various specialists to come together and identify the best treatment strategy for each patient. That way we can maximize cure for this deadly disease.